Welcome to This Explainer. Today, we're decoding the intense, mysterious pain pathways of cluster headaches and related severe cranial conditions. If you've ever wondered exactly what's happening in the brain when a headache goes from being just a typical nuisance to a localized, completely debilitating event, well, you're definitely in the right place.
Let's dive right in by looking at a shockingly small number, less than 0.1%. We're talking about conditions that affect fewer than 1 in 1,000 people. But while that's extremely rare, for the people who actually suffer from these localized headaches, the impact is just profound. We aren't talking about your standard tension headache here. No, this is intense pain that typically strikes around the eye, usually just on one side of the head, and it comes with some very distinct, hard-to-miss physical features.
Here's our roadmap for this explainer. We'll start by defining severe TAC headaches. Then we're tracing the pain signals, looking at the hypothalamic and vascular triggers, comparing the 5 variations of TACs, and finally, covering the targeted treatments for relief.
Let's kick things off with Section 1, Defining Severe TAC Headaches. So the crucial starting point here is breaking down this overarching, kind of intimidating medical term, trigeminal autonomic cephalgias, or TACs for short. It sounds super complex, right? But it actually translates literally from its Greek roots. Cephal just means head, and algia means aches or pains. Trigeminal, well, that tells us exactly where it's happening, referring to the trigeminal nerve, which is the main sensory nerve of your face. And finally, autonomic refers to the involuntary physical cranial reactions that pop up alongside the pain. Put all of that together, and it perfectly describes head pain linked to the facial sensory nerve combined with those involuntary physical reactions.
Moving right along to Section 2, Tracing the Pain Signals.
Now that we've got the terminology down, let's zoom way in. Medical science calls this pathway the trigeminal autonomic reflex. It essentially maps out the exact 4-step journey that a pain signal takes. Step 1, there's stimulation of the afferents, those are the sensory nerve fibers, right in the cranium. Step 2, that signal travels down to the nucleus of the trigeminal nerve. Step 3, it shoots up to the higher brain center, which is where we actually perceive the pain. And then, Step 4, it triggers a reflex back out as a physical autonomic reaction. It is a wildly rapid, completely devastating loop of communication inside the nervous system.
What's truly fascinating here is the stark contrast in the physical autonomic outflow caused by these signals. On one side, we see an overactive parasympathetic response. So this is what causes cranial features like excessive tearing of the eye, a running nose, nasal congestion, and eyelid swelling. But conflicting directly with that is an inhibited sympathetic response, which causes ptosis or a drooping eye and a constricted pupil. So your nervous system is essentially slamming the gas pedal on some involuntary responses, like the tearing, while entirely cutting the brakes on others, all at the exact same time. It's physiological chaos.
So, what sets this off? That brings us to Section 3, Hypothalamic and Vascular Triggers. When looking for a trigger, medical science strongly implicates the posterior region of the hypothalamus. Think of this as our internal biological clock. And we know it's involved because these specific headaches, they don't just happen randomly. They act with a disturbing clockwise regularity. For single attacks, they show striking seasonal variations, and they follow a very clear relapsing and remitting course. All of these clock-like patterns point a massive, undeniable arrow straight at the hypothalamus as the origin of the illness.
Alongside that hypothalamic activation, there's also the vascular theory to consider. This theory suggests that the clinical symptoms of these headaches, especially the cluster headaches, are actually triggered by neurogenic inflammation. Specifically, inflammation occurring within the walls of the cavernous sinus, which is basically a hollow space sitting right behind your eyes. It's a localized inflammation that, when combined with your biological clock going awry, sets off that entire intense trigeminal reflex we just talked about.
Now let's see how this all manifests in Section 4, 5 variations of TACs.
There are massive variations in how these pain signals actually show up in patients, and laying it out like this is essential. Just look at the extremes here. On one hand, you have hemicrania continua, which brings constant moderate intensity headaches that can literally last for days. Contrast that against Sunct and Suna, where the burning, stabbing pains last only seconds, but they can strike an unbelievable 100 to 200 times in a single day. It's just staggering.
We absolutely have to highlight cluster headaches here, as they're the most common of the 5 variations. This condition predominantly affects men, usually with an onset between the ages of 20 and 50. These episodes involve severe, unilateral pain around the eye lasting anywhere from 15 to 180 minutes.
Sometimes they come in clusters for weeks or even months, followed by long periods of remission. But guys, the pain is so incredibly intense and severe that the medical community has literally given it the dark clinical nickname of the suicide headache. This is exactly why understanding this condition matters so much. These patients are experiencing some of the most severe pain known to medicine, and they require immense support.
Alternatively, if we look at paroxysmal hemicrania, it kind of flips the script on cluster headaches in a few key ways. Instead of predominantly affecting men, it presents with a higher incidence in women. The attacks themselves are much more frequent throughout the day, but they do have a noticeably shorter duration than a typical cluster headache.
Now, before we even start talking about specific medications for any of these variations, there's a vital, non-negotiable medical prerequisite. Everyone presenting with any of these 5 TAC syndromes requires an MRI. This is absolutely crucial to assess the brain and make sure there isn't some other dangerous underlying pathology, like a tumor, for instance, that's actually causing the pain.
That brings us to our final part, Section 5, Targeted Treatments for Relief.
To fight back against cluster headaches specifically, doctors deploy a highly targeted medical arsenal. The frontline defense? Often it's 100% oxygen, usually given via a Hudson mask for about 20 minutes. Doctors also rely heavily on triptans, like sumatriptan, which are administered either subcutaneously or intranasally. Then you have bridging treatments involving steroids or occipital nerve blocks and preventative strategies using medications like verapamil just to try and keep those clusters at bay. But the treatments shift dramatically when we look at the other types. Paroxysmal hemicrania and the constant daily pain of hemicrania continua actually respond selectively and pretty dramatically, often within just a matter of days, to a very specific non-steroidal anti-inflammatory drug. It's called indomethacin. It's like a night and day difference for those specific conditions.
And for those ultra-rapid Sunic and Suna variations, where remember patients might suffer hundreds of attacks in a single day, those standard treatments of oxygen and indomethacin, they don't help at all. Instead, to calm that stabbing, rapid-fire nerve pain, these specific conditions require an anti-epileptic medication called lamotrigine.
So as we wrap up this explainer, we're really left looking at a fascinating frontier in neuroscience. If a subtle error in our internal biological clock is what triggers this devastating pain reflex, well, how close are we to finding the ultimate reset button? As we decode these complex neural pathways, what new targeted therapies could we eventually unlock to cure the pain before the clock even strikes?